Hello friends, today we are going to discuss about the American Association of Clinical Endocrinologists guidelines for diagnosis and treatment of postmenopausal osteoporosis, and I'm Dr. Santosh Abraham. I'm working as a specialist registrar in endocrinology and diabetes at Scarborough General Hospital. So the working group of WHO had established an operational definition of postmenopausal osteoporosis. So this is based on the T-score, and a T-score of minus 1.0 or above is considered as normal. Between minus 1.0 and minus 2.5 is considered as osteopenia, and anything above minus 2.5 or below is considered as osteoporosis, with severe or established osteoporosis as minus 2.5 or below with a fragility fracture. So they recommend evaluating all postmenopausal women aged more than 50 years of age for osteoporosis risk. A detailed history, physical exam, and clinical fracture risk assessment with FRAX or other tools are recommended. To consider bone mineral density (BMD) testing based on clinical fracture profile, and when BMD is measured, DEXA is usually used, lumbar spine and hip. Distal 1/3 of radius is used if lumbar spine and hip cannot be done. So the assessment for fracture risk and osteoporosis in postmenopausal women is as given as in this table. So a medical history and a physical examination to identify any prior fractures without major trauma. Clinical risk factors for osteoporosis. Age is an important risk factor, so more than 65 years or equal to 65 years. Low body weight, smoking, early menopause, excessive alcohol intake, more than 3 drinks per day. Any conditions predisposing to secondary osteoporosis, any height loss or kyphosis, and risk factors for falling. And the patient's reliability and willingness to accept interventions. Lateral SMITE imaging with standard radiography or vertebral fracture assessment in patients with unexplained height loss or undocumented prior spinal fractures, or glucocorticoid therapy equivalent to more than or equal to or more than of 5 milligram of prednisolone per day for 3 months. So BMDs are suggested in those at increased risk for osteoporosis and fractures and willing to consider pharmacological therapy if low bone mass is documented. So BMD is recommended for all women aged 65 years or older. In younger postmenopausal women with a history of fracture without major trauma, starting or taking long-term systemic glucocorticoids, with radiographic osteopenia, with clinical risk factors for osteoporosis, that is low body weight, cigarette smoking, family history of spine or hip fractures, early menopause, or secondary osteoporosis. So risk factors included in FRAX are usually the country of residence, ethnicity, age, sex, weight, height, family history, personal history of fragility fracture, glucocorticoid use, rheumatoid arthritis, smoking, alcohol use, secondary osteoporosis, specifically type 1 diabetes, osteogenesis imperfecta, untreated long-standing hypothyroidism, hypogonadism, or premature menopause, chronic malnutrition or malabsorption, and chronic liver disease. Factors which increase the risk of falling and fracture and hence the fractures should be assessed for or should be looked into, such as neurological disorders like Parkinson's disease, seizure disorder, peripheral neuropathy, prior stroke, dementia, impaired gait or balance, autonomic dysfunction with orthostatic hypotension. So these conditions need to be looked into. Also, problems with vision, hearing, frailty, proximal myopathy, sarcopenia could also lead to increased risk of falls. Medications, especially antihypertensives, sedatives, hypnotics, narcotics could do that. And environmental factors like poor lighting, stairs, slippery floors, wet, icy or uneven pavement, uneven roadways, walking large dogs, throw rugs, positioning in a wet or dry bathtub, all these could predispose to increased risk of falling and fracture. So these should be assessed. So the indications for bone mineral density testing again are all women 65 years of age or older, all postmenopausal women with a history of fractures without major trauma, with osteopenia in radiography, or on long-term systemic glucocorticoids. Other perimenopausal or postmenopausal women with risk factors, low body weight, long-term systemic glucocorticoid therapy, family history of orthoporotic fractures, early menopause, current smoking, excessive consumption of alcohol, and conditions as which lead to secondary osteoporosis. So osteoporosis once again is diagnosed based on the presence of fragility fractures in the absence of other metabolic bone disorders, and even with a normal T-score. So that's very important. Even with a normal T-score, osteoporosis can be diagnosed in the presence of fragility fractures. It is also diagnosed based on a T-score of -2.5 or lower in the lumbar spine, femoral neck, total hip, or 1/3 of distal radius. That is 33% of radius, even in the absence of a prevalent fracture. Even if a diagnosis of osteoporosis is made with a T-score, the diagnosis will persist. That is, the diagnosis cannot be revoked even if the subsequent T-score improves. Osteoporosis can also be diagnosed in patients with a T-score between -1.0 and -2.5. That is, in patients with osteopenia with increased fracture risk using the FRAX tool. So this is the diagnosis, the ACE diagnosis table for osteoporosis postmenopausal women. So when osteoporosis, I would like to highlight something here. About the role of trabecular bone scoring in adjusting fracture risk. That's when you are trying to assess the fracture risk in osteopenic patients. So TBS is basically a textural index. So it measures pixel gray level variations in the lumbar spine DEXA image, providing an indirect index of trabecular microarchitecture. So the variability in the 2D DEXA image is presumed to correlate with the absorption parameters in the 3D bone according to a mathematical relationship. So it can be usually and easily available through a FDA approved software, and it is installed in compatible DEXA systems. So high TBS values correlate with homogeneous bone texture, while low values are indicative of more variable bone texture. The TBS predicts Fracture risk independent of bone mineral density, and it enhances fracture risk prediction capabilities of fracs. Low TBS values increase fracs estimated risk, while high TBS values reduce it. Age substantially alters the impact of TBS on fracs estimated risk, and the effect of TBS on fracture risk being much greater for younger women. TBS has been shown to have a less impact in older women, but it could be due to the falls that become more common in advancing age, and which has a greater role in fracture risk. TBS may be especially useful in clinical situations such as type 2 diabetes and primary hyperparathyroidism, where fracs without TBS may underestimate the fracture risk. Another point which I want to tell you is about inaccuracies in BMDs. It could result from a variety of factors: positioning errors, inadequate knowledge of how to eliminate fractured vertebra or vertebrae with more severe osteoarthritis, non-adherence to guidelines published by the International Society for Clinical Densitometry, which recommends measurement of at least 2 consecutive vertebrae, artifacts, errors in the use of ethnic or gender-specific databases, faulty input to the fracs calculator, failure to exclude extraskeletal calcifications, inaccurate reporting of results. For example, when you report patient has lost 30% of BMD or bones are equivalent to an 8-year-old, those are all inaccurate reporting. And failure to compare results or comparing results from different machines or following major software changes. So when osteoporosis is diagnosed, what is an appropriate evaluation? Evaluate for causes of secondary osteoporosis. Evaluate for prevalent vertebrate fractures. Consider using bone turnover markers in the initial evaluation and follow-up of osteoporosis patients. Elevated levels can predict more rapid rates of bone loss and higher fracture risk. So these are the causes of secondary osteoporosis in adults. So table on the left hand side you can see the endocrine or metabolic causes such as acromegaly, diabetes 1 and 2, growth hormone deficiency, hypercortisolism, hyperparathyroidism, hypothyroidism, hypogonadism, hyperphosphatasia, pregnancy even, and nutritional conditions such as alcoholism, anorexia, calcium deficiency, chronic liver disease, malabsorption syndromes, on total parenteral nutrition and vitamin D deficiency. And lots of drugs like antiepileptics, aromatase inhibitors, chemotherapy, medroxyprogesterone acetate, glucocorticoids, GnRH agents, heparin, lithium, PPIs, SSRIs, even SGLT2 inhibitors, very important, thiazolidinediones like pioglitazone, thyroid hormone, and connective tissue disorders like Ehlers-Danlos syndrome, homocystinuria, Marfan's, osteogenesis imperfecta, and others like AIDS or HIV, ankylosing spondylitis, COPD, Gaucher's, hypercalciuria, immobilization, major depression, hemophilia, myeloma, organ transplantation, renal failure, renal tubular acidosis, rheumatoid arthritis, thalassemia, etc. So vertebral fracture detection. This is very important because it's the most common osteoporotic fracture and it indicates a high risk for future fractures even when the T-score does not meet the threshold for osteoporosis. Most vertebral fractures remain undetected unless specifically sought by imaging techniques like spinal X-ray or vertebral fracture assessment. VFA is a technique to assess vertebral fractures with DEXA technology and can often be done at the same time with the DEXA. So lateral spine imaging with standard radiography or VFA with DEXA is indicated when the t-score is less than -1.0 with one or more all of the following is present. Women aged more than 70 years or men aged more than 80 years. Historical height loss more than 4 cm. Self-reported but undocumented prior vertebral fracture. Glucocorticoid therapy equivalent to more than 5 mg prednisolone for more than 3 months. In adult patients with unexplained height loss or back pain, thoracic and lumbar radiography or VFA by DEXA is indicated in prevalent vertebral fractures, and this will alter clinical management. So lab tests to consider in detecting secondary osteoporosis: CBC chemistries including calcium phosphate, total protein, albumin, LFTs, renal function tests, and 24-hour collections for calcium, sodium, and creatinine excretion. Serum vitamin D. Additional tests could be PTH, TSH, TTGs, serum protein electrophoresis with free kappa and lambda light chains, urinary free cortisol, or other tests for suspected adrenal hypersecretion, serum tryptase, or other tests for mastocytosis, bone marrow aspiration and biopsy for marrow diseases. So bone turnover markers. They provide a dynamic assessment of skeletal activity and are useful modalities for skeletal assessment. So elevated levels can predict more rapid rate of bone loss and associated with increased fracture risk independent of bone mineral density. These markers also respond quickly to therapeutic intervention. Changes in markers have been associated with bone response to therapy and reduction of fracture risk. So in 2010, the International Osteoporosis Foundation proposed that the serum C-terminal telepeptide type 1 collagen, CTX, and serum carboxy-terminal propeptide of type 1 collagen, PINP, can be used as reference analytes. So CTX and PINP are used now as the references for BTM. The preferred resorption marker is CTX and the preferred formation marker is PINP. So CTX is usually done in the fasting state and ideally at the same time in the morning every day, every time you do it. So the problems with the use of BTMs are, one is their cost, and there is lack of appropriate reference ranges reported by commercial labs, and if the patient has renal insufficiency, then you could do the bone specific alkaline phosphatase. So what are the fundamental measures of bone health? To measure the serum 25-hydroxy vitamin D levels in patients who are at risk for vitamin D insufficiency, particularly those with osteoporosis. Maintain the serum 25-hydroxy vitamin more than 30 nanogram per ml in patients with osteoporosis. Supplement with D3 if needed with a daily dose of 1000 to 2000 international units. And higher doses of vitamin D3 may be necessary in patients with factors such as obesity, malabsorption, older age. The supplemental dose could even be increased up to 4000. Counseling and communicating to the patients is very important to maintain adequate dietary intake of calcium. So a total intake of more of 1200 milligram per day for women aged more than 50 years is recommended. So women of 50 or 50 plus are advised to have 1200 milligram per day of calcium. Limit alcohol to no more than 2 units per day. This is because alcohol could increase the risk of falls and hence could predispose to fractures. Also, it could produce calcium deficiency and chronic liver disease. Chronic liver disease, which will in turn will predispose to vitamin D deficiency. So, limit the alcohol to no more than 2 units per day. Counsel the patients to avoid or stop smoking. This is because smoking relates to increased metabolism of endogenous estrogen, or direct effects of cadmium on bone metabolism has been shown. A meta-analysis even showed a higher risk of fractures in current smokers compared with previous smokers. And counsel patients to maintain an active lifestyle, including weight-bearing balance and resistance exercises. Provide counseling on reducing risk of falls, particularly among the elderly. Consider referral for physical therapy, which may reduce discomfort, prevent falls, and improve quality of life. Other supplements and nutrition. If the patient is having hypomagnesemia, especially if the patients who are at risk, such as those with GI malabsorption, chronic liver disease, or renal tubular loss, or those using proton pump inhibitors, should be advised about the supplementation of magnesium. So magnesium is required for adequate calcium absorption, and if body stores are adequate, magnesium supplementation does not increase bone mineral density. Vitamin A and K. Excessive intake of vitamin A, more than 10,000 units, international units per day, should be avoided, as this has shown to be detrimental for bone. Vitamin K may reduce bone turnover and bone loss in postmenopausal women. Patients should be advised to limit caffeine intake to less than 1 to 2 servings. This is because studies have shown an association between consumption of caffeinated beverages and fractures. It might lead to a slight decrease in intestinal calcium absorption and increase in urinary calcium excretion. Adequate protein intake helps minimize bone loss among patients who have suffered hip fractures. So the recommended daily allowance is 0.8 gram per kilogram for protein. Now, fall prevention. Falls are one of the precipitating causes of most fractures and are effective. So falls prevention forms an effective osteoporosis treatment regimen. So approximately 1/3 of the people over 65 and roughly half of those above 80 years or older fall each year. 20 to 30% of persons who fall suffer moderate to severe injury. So what are the measurements for prevention of falls? Minimize clutter, remove loose wires, use non-skid mats, install handrails in bathrooms, halls and long stairways, light hallways, stairwells and entrances. Encourage patients to wear sturdy, low-heeled shoes. And lifestyles issues like ensuring adequate intake of calcium and vitamin D, consume a balanced diet, avoid use of tobacco and alcohol, and regularly perform weight-bearing and balance exercises. So regular weight bearing exercises, walking 30 to 40 minutes per session plus back and posture exercise for a few minutes 3 to 4 days per day should be advocated throughout life. Strength training leads to small yet significant changes in bone mineral density. Exercises help to show bone loss attribute to slow bone loss attributable to disuse, improve balance and muscle strength, and ultimately help reduce the risk of falls. Individuals with severe osteoporosis should use caution when engaging in activities that involve forward spine flexion and rotation, lifting heavy weights, or even side bending of the trunk, because these maneuvers exert compressive force on the spine that may lead to fracture. Now, who needs pharmacological therapy? With osteopenia or low bone mass and a history of fragility fracture of the hip or spine, with a t-score of minus 2.5 or lower in the spine, femoral neck, total hip, or 1/3 of the radius, with a t-score between minus 1.0 and minus 2.5. If the TBS fracs or fracs, such as 10-year probability for major osteoporotic fracture, is more than 20%, or the probability of the 10-year probability of hip fracture is more than 3%. So consider patients with a recent fracture or fractures while on approved osteoporosis therapy. Multiple fractures while on drugs causing skeletal harm, very low t-score, minus 3.0 or less, and high risk for falls or history of injurious falls, and very high fracture probability by fracs, major osteoporosis fracture risk increasing more than 30%, or hip fracture more than 4.5. So you have to consider therapy for all these patients. Also, who have been diagnosed with osteoporosis but are not at a very high fracture risk. So how is the treatment monitored? So first you have to do a baseline axial DEXA and repeat this DEXA every 1 to 2 years until the findings are stable. So continue with the follow DEXA with every 1 to 2 years or at a less frequent interval. Monitor serial changes in lumbar spine, totals, hip or femoral neck, BMDs. So follow-up of the patient should be ideally conducted in the same facility with the same DEXA system, even with the same operator. That is what the ACE suggests. So consider using BTMs for assessment of patient compliance and efficacy of therapy. So reductions in BTMs are seen with anti-resorptive therapy and have been associated with fracture reduction, and increases are seen with anabolic therapy, and these are taken as a good response to anabolic therapy. So what is a successful treatment of osteoporosis? Consider stable or increasing bone mineral densities with no evidence of recent fractures or vertebral fracture progression as response to therapy for osteoporosis. Another is by taking the BTMs. So if they are if they're taking the anti-resorptive agents, look for a decrease in the BTM. If they're on anabolic therapy, significant increase in bone formation markers. Consider alternative therapy or reassessment for cause of secondary osteoporosis in patients who have recurrent fractures or significant bone loss while on therapy. This is very important. Even if the problem cannot be solved on therapy, you have to consider other therapies or reassessment for causes of secondary osteoporosis. And how long? Limit the treatment with abaloparatide and teriparatide for 2 years. Follow abaloparatide teriparatide therapy with bisphosphonate or denosumab. Limit therapy with Romosozumab to 1 year and follow with bisphosphonate or denosumab. So this is with the newer therapy. For bisphosphonates, consider bisphosphonate holiday after 5 years of treatment if the fracture risk is no longer high, as when the t-score is greater than minus 2.5, or if the patient has remained fracture free. Other risks are osteonecrosis of the jaw and atypical femoral fractures. So, osteonecrosis of the jaw is defined as the presence of exposed bone in maxillofacial region that did not heal within 8 weeks after identification. The atypical femoral fractures are located along the femoral diaphysis, just distal to the lesser trochanter, and the fracture is associated with minimal or no trauma, as in a fall from a standing height or less. The fracture line originates at the lateral cortex and is substantially transverse in orientation. Fracture is usually non-comminuted or minimally comminuted. Localized periosteal or endosteal thickening of the lateral cortex is present. So because of these concerns, usually the duration is always taken into account. So for oral bisphosphonates, consider bisphosphonate holiday after 5 years of treatment if fracture risk is no longer high, such as when the t-score is greater than minus 2.5 or the patient has remained fracture free, but continue treatment up to additional 5 years if the fracture remains high. For oral bisphosphonates, in patients with very high fracture risk, consider bisphosphonate holiday after 6 to 10 years of stability. But this is in difference to this is with respect to solidronate, consider bisphosphonate holiday after 3 years in high risk patients, or until the fracture risk is no longer high, but up to 6 years in high risk patients. So for all bisphosphonates, if the fracture risk is high, 6 to 10 years. If the fracture risk is low, or if the BMD is normal, or if the patient has remained fracture free, then 5 years. But for solidronate, 3 years if the fracture risk is no longer high, and 6 years in high risk patients. So ending of bisphosphonate holiday should be based on individual patient circumstances, such as increase in fracture risk, decrease in bone mineral density, and an increase in BTM. So if the fracture risk increases, if the BMD is decreasing and the BTM is increasing, the bisphosphonate holiday should be stopped. What is the role of concomitant therapeutic agents? The role of concomitant use of therapeutic agents. The AACE does not recommend them. What is the role of sequential use of therapeutic agents? So if the anti-resorptive therapy is not functioning well, follow treatment with an anabolic agent, with a bisphosphonate or denosumab, to prevent bone density decline and loss of fracture efficacy. Role of vertebral augmentation or compression fractures. vertebroplasty and kyphoplasty are not longer recommended as first-line treatment for vertebral fractures because they have no clear benefit for overall pain and potentially increases the risk for fractures in adjacent vertebrae. So when should be the referral to clinical endocrinologists or osteoporosis specialists be considered? For those in fragility fractures, so usually it is referred to osteoporosis specialist or a fracture liaison team. When a patient with normal bone mineral density sustains a fracture without major trauma, when recurrent fractures or continued bone loss in patient receiving therapy without obvious treatable causes, when BMD is unexpectedly low, or when osteoporosis initial features such as young age, unexplained artifacts on BMDs, unexplained lab studies, including high or low ALPs or phosphates. So a few notes about medications used. So denosumab, it's a fully humanized monoclonal antibody. It prevents receptor activator of nuclear factor kappa-B ligand from binding to its receptor. So NF-kB is prevented from binding to its receptor. And also the receptor activator of, so thus it reduces the differentiation of precursor cells into mature osteoclasts, and also it decreases the function and survival of activated osteoclasts. So by preventing NF-kB to bind to its receptor, it reduces the differentiation of precursor cells into mature osteoclasts and hence decreases the function and survival of the osteoclasts. The dose is 60 mg by subcutaneous injection every 6 months. The Freedom trial, it showed that anti-fracture efficacy as early as 12 months. So it's considered as a broad spectrum, and studies up to 10 years indicate persistent fracture protection and a good safety profile. And switching from bisphosphonates to denosumab results in additional gains in bone mineral density. That's what the Freedom trial demonstrated. So it's contraindicated in patients with hypocalcemia who have hypoparathyroidism or osteomalacia, and calcium and vitamin D intake should be adequate to minimize the risk of hypocalcemia. When treatment with denosumab was stopped after 2 to 8 years, BMD decreased rapidly and bone turnover markers increased to values above baseline by 12 months after discontinuation. So protection from vertebral fractures is quickly lost, but the risk does not usually exceed in untreated patients. So the BMD decreases rapidly when the denosumab is stopped. So protection from fractures is lost, but the risk does not usually exceed than in untreated patients. So multiple vertebral fractures upon stopping denosumab has been reported. So therefore, the drug holidays are not recommended. It's not certain how these fractures occur. So it underpins the importance of not missing a dose of denosumab. So if denosumab is discontinued, it should be transitioned to an anti-resorptive therapy. Again, using an IV anti-resorptive therapy may not be effective if it is given before the inhibitory effect of the denosumab has weaned off. So drug holiday is not recommended. Important not to miss a dose. If discontinued, should be transitioned to anti-resorptive therapy, because when you stop the denosumab, the BMDs fall quickly and the risk of fractures increases. So calcitonin, you have injectable and nasal recombinant calcitonin, 100 international units given subcutaneously daily. It could be also given intramuscularly. Nasal spray calcitonin is 200 international units daily. main contraindication, drug hypersensitivity. So skin testing is recommended before treatment if you suspect sensitivity to the drug. So it reduces the risk of new vertebral fractures. It is not effective in reducing vertebral fractures in men. It does not reduce hip or non-vertebral fractures. So it is mainly in vertebral fractures. Minimal increase in BMD in the spine in women more than 5 years after menopause. Does not increase BMD at other sites other than the spine. Primarily because more effective agents are available, limiting the use of calcitonin has to be considered as long-term treatment for osteoporosis. But it has got analgesic effects, so effective short-term prescriptions are often given to patients with painful vertebral fractures. A meta-analysis even have shown that there's a high incidence of malignancy in calcitonin treated patients. So this was in trials of nasal spray calcitonin. But the FDA did not find any sufficient evidence to establish a causal relationship between calcitonin and cancer risk. But it's usually urged that the risks and benefits of the osteoporosis treatments have to be weighed for individual patients. So how about raloxifene? So it is used in postmenopausal osteoporosis as well as for the reduction of risk of breast cancer, or in women with a high risk of breast cancer and osteoporosis. So it is 60 mg per day. It's contraindicated in in women who want to be pregnant, women of childbearing potential, and in women who have history of venous thromboembolism or who are hypersensitive. So it reduces the risk of fractures of the spine, but neither non-vertebral nor hip fracture efficacy has been demonstrated. So it's only applicable to spine fractures. It's not indicated for the treatment of invasive breast cancer or for reduction of the risk of recurrence of breast cancer or for the reduction of risk of non-invasive breast cancer. So it has not been shown to reduce hip or non-vertebral fracture. Only it applies for the spinal fractures. So it may not be the best treatment option in patients with osteoporosis. But if in patients who have a high risk of spinal fractures, a very low BMD in spine, and if these patients are at high risk of breast cancer, it may be an acceptable initial choice. So usually the AACE does not recommend the use of 2 antiresorptive drugs in combination for osteoporosis, but patients at risk of hip fracture who are taking raloxifene for their breast cancer could have a bisphosphonate or denosumab added for hip fracture risk reduction. So selective estrogen modulators or plus conjugated equine estrogens. So basically it's basidoxifene conjugated estrogens. The selective estrogen receptor modulators basidoxifene used with the conjugated equine estrogens. So they increase BMD at multiple sites over 2 years. Basidoxifene conjugate estrogen therapy significantly reduces the frequency and severity of hot flashes and improves vulvar vaginal atrophy, and it has a good tolerance. It's better tolerated. But there is an increased risk for endometrial cancer in women with a uterus. And also it would reduce hot flashes, but the adverse effects on the endometrium and breast associated with the estrogen therapy also has to be considered. So indications are women with a uterus and with moderate to severe vasomotor symptoms and with the risk of osteoporosis. But overall, it has very limited use in the prevention of treatment of postmenopausal osteoporosis and likely would not be selected in the future. So anabolic steroids, abaloparatide and teriparatide. Abaloparatide is a modified PTH related peptide, and teriparatide is a recombinant human PTH. So these are considered anabolic agents, and they work by reducing bone resorption. So they are approved by the FDA for initial treatment of women with postmenopausal osteoporosis who are at high risk of fracture or have failed treatment or have been intolerant to previous osteoporosis therapy, who have failed bisphosphonates. So teriparatide is also approved for the treatment of glucocorticoid-induced osteoporosis and treatment of osteoporosis in men also. Both are injected subcutaneously. Abaloparatide does not require refrigeration. So it is prudent to measure calcium, PTH and vitamin D levels and alkaline phosphatase to rule out Paget's disease before treatment. Alkaline phosphatase to rule out Paget's disease before treatment has to be done. So patients who lose BMD in the hip with teriparatide are protected against vertebral fractures. Basically it improves the bone geometry and microarchitecture. The side effects are mild and transient: nausea, orthostatic hypotension, leg cramps, hypercalcemia. And if the serum calcium is to be measured, the blood should be drawn at least 16 hours after drug administration. Now, due to an increased incidence of osteosarcomas in rats, abaloparatide and teriparatide should not be used in patients at increased risk of osteosarcoma. That is, those with Paget's disease, open epiphysis, history of irradiation, unexplained elevation of ALPs of skeletal origin. The annual incidence of osteosarcoma in women aged 50 is approximately 1 in 250,000. So in any forms of hyperparathyroidism, abaloparatide and teriparatide should not be used because of the risk of hypercalcemia. Both of these drugs should not be used no longer than 2 years in total duration. And when the treatment with teriparatide is stopped, BMD decreases quickly during the following year, but the fracture reduction may persist for 1 to 2 years. So there is no apparent rationale for a drug holiday or a washout period between the end of the anabolic therapy and initiation of antidisruptive therapy. So it is probably not advisable to use teriparatide if denosumab is stopped, but teriparatide may be added to ongoing denosumab. So there is no drug holiday between the end of anabolic therapy and initiation. So it has to be overlapped. If denosumab is stopped, you cannot stop denosumab and start teriparatide, but teriparatide could be added to the ongoing denosumab therapy. So you cannot stop basically the antidepressant and start with an anabolic therapy unless you have intolerance, but you can add on to increase the gain in BMDs. So what about the long-term studies? Both abaloparatide and teriparatide have been shown to increase PMD, that's for sure, and it reduces the risk of vertebral and non-vertebral fractures. But the incidence of hip fracture was low in these trials. So whether these anabolic agents protect against hip fracture is not known. So gains in BMD were greater with abaloparatide compared with teriparatide, especially in femoral neck, total hip, and 1/3 radius. So fracture reduction was also numerically greater with abaloparatide than with teriparatide. So abaloparatide could be having a superior profile than teriparatide with these studies. And finally, about Romosozumab. So it's a monoclonal antibody against sclerostin. Sclerostin binds with the WNT receptor. It inhibits the differentiation of precursor cells into mature bonds, forming the osteoblasts. So blocking sclerostin binding to osteoblasts allows osteoblast activity to increase. So if the sclerostin is bound with the osteoblast, they are inhibited. So if the sclerostin binding is blocked, the osteoblast activity increases. So by binding with the WNT, by binding the sclerostin, the WNT receptor is not activated, and thus the osteoblastic activity increases. So Romosozumab is a monoclonal antibody, so it's directed against sclerostin, so it binds with the WNT receptor. So thus it increases the osteoblastic activity. So BTM suggests an early anabolic effect. Bone density increases are dramatic, both in cross-sectional area and bone repair, so showing modeling and remodeling respectively. So there were 2 large trials for Romosozumab. In the bigger trial, they received spontaneous Romosozumab for 12 months, and then patients received denosumab. In the other trial, they received monthly Romosozumab or oral alendronide for 12 months. Then they all received alendronide. So both the trials showed significant reductions in radiographic vertebral fractures at 12 months and 24 months. So it was more for the Romosozumab followed by denosumab compared with the placebo and denosumab. So it was 75% and around 50% with denosumab followed by alendronide compared with alendronide for 2 years alone. So clinical fractures were also significantly reduced in both trials. So non-vertebral fracture reduction and hip fracture reduction were significant in the smaller trials. So greater gains in BMD were mainly seen in the lumbar spine, that is 9.8%, femoral leg followed by the femoral leg, and the total hip. So it is viewed as a rescue drug in the future for patients at very high fracture risk. It is also an option with previously treated patients who have been previously treated with teriparatide or abaloparatide, so who have failed, but treatment with Romosozumab could be possible. It can be used in patients with prior radiation exposure, but concerns about serious cardiovascular events limits its use currently. So there is a black box warning. So it has to be used in caution who have had recent myocardial infarction or stroke, or it could not even be used at all in those patients. and it is not currently approved for male osteoporosis. I know that this presentation was a bit fast because we had a lot of topics to cover, but this is one of the most important guidelines for osteoporosis, which is very, very detailed and comprehensive. So I would urge all of my colleagues to read the AACE guidelines for osteoporosis. Thank you.